Okay, so I'm going to talk to you about an equally complex topic, fluid balance in acute brain injury patients. And it's complex because I have no declarations of interest. It's complex because of the diversity and heterogeneity of the patient population we're going to talk about in 15 minutes. I'll try to do a practical approach. So this is a very nice consensus that was put together because of the profound number of studies in this area and unfortunately a lot of conflicting literature. And so it was felt to have to do a very deep dive and systematic review of all of the literature contributing to these types of comatose patients and also develop some kind of a consensus. They focused on sort of three major topics, and that's how I'm going to organize my talk today. One is these are not patients to be considered, in shock who are actively bleeding with polytrauma. Those are additional different conditions where there's a melding of approaches. Really, to talk about, there's a whole amount of literature just on the general fluid management of these specific brain injuries. The role of hyperosmolar fluids, both in maintenance, resuscitation, and for hyperosmolar therapy for intracranial pressure events. And then finally, probably a large topic in and of itself, as you've already been alluded to, is in subarachnoid hemorrhage patients who have delayed cerebral ischemia and how you might manipulate fluid therapy. So if you were to go to this consensus recommendation, you would find a lot of these specific questions addressed. Things like colloid versus crystalloid, albumin versus crystalloid, buffered versus standard crystalloids, the choice of the fluid, hyperosmolar, isotonic, when you should start hyperosmolar therapy with a trigger or prophylactically, with monitoring, without monitoring, things like this. In general, just to take it off the table, hypotonic solutions are generally avoided in these types of comatose neuro patients. And the reason for that is that the blood-brain barrier is water permeable, and in general is what we take advantage of with the hypertonic solutions, right, to try to dehydrate the brain and to reduce intracranial pressure. On the flip side of that, there is a very real possibility of creating an active fluid shift that's acute and that might worsen an intracranial process. Similarly, we try to avoid dextrose additions because a lot of our focus in reducing secondary brain injury is to create a strict normoglycemic environment. So then there's this question of crystalloids versus colloids, and the history of all of this literature is really compelling to want to favor colloids, and that's why it's so aggressively studied. But because crystalloids fluid quickly diffuses across semi-permeable barriers, and because it's about 75% of that extracellular fluid is interstitial, you kind of have to give about 4 times as much of the crystalloid solution to really replace like a unit of equivalent plasma or whole blood. Having said that, when you have these tight endothelium barriers of the blood-brain barrier with a mechanical injury of acute brain injury, you really allow hypothetically and physiologically plausibly serum and fluid protein transport into the brain parenchyma where it gets lodged. You can imagine it attracting vasogenic cerebral edema, which contributes to your problem of increased intracranial pressure. And then you can physiologically plausibly see elevated the albumin extravasation if you're administering it to increase that interstitial oncotic pressure, worsening the cycle of vasogenic edema. This has been shown in TBI in the SAFE trial, in post-hoc analysis as well, where you have fluid resuscitation using albumin is associated with a higher mortality rather than the use of saline. Interestingly, this was not as well supported in the subarachnoid hemorrhage patient population. This was a pilot study where they were doing a dose escalation phase 2 approach to try to see what is the safety of albumin in subarachnoid hemorrhage patients, because it is very compelling to try to use that. And they found some signal that it might be neuroprotective in subarachnoid hemorrhage. Unfortunately, the phase 3 was never completed. Actually, this is Matthew is here in the audience. This is a really nice review and a very nice approach and explanation. The way I like to think about it is there's sort of a 2 or 3-pronged approach. You have things that you can manipulate in terms of your fluid administration, for your intravascular space. You have your cardiac function to monitor and to manipulate. And then you have to understand your vascular tone and permeability, which is a little bit harder to really measure in the bedside. And then at the end of it, your output, what you're able to measure to really understand, there's lots of different mediators in this pathway, and you kind of have to tease apart using just your knowledge of, is there cerebral edema happening? Is that cerebral edema all contributing to your intracranial pressure? What is your cerebral blood flow and oxygenation? This is a very complicated balance where we're not actually very, very precise at the bedside, and we can only hypothesize that there are many pathomechanisms at play in parallel. Recently, there was a very nice definitive study in a very large TBI cohort across multiple countries and multiple centers, 2 different prospective observational studies of severe TBI. And it was shown definitively that hypervolemia, or high fluid balance state, is associated with ICU mortality and also a worse functional outcome. I think it's interesting that in this study, whereas the balance seems to influence that mortality and functional outcome, the amount of higher fluid input that is given is actually not associated with ICU mortality. I think this is TBI and subarachnoid hemorrhage are very different topics, but at the same time, it's a very compelling thing because we're frequently chasing the fluid balance in subarachnoid hemorrhage patients as they have the natriuresis and the fluid that follows. So moving away from hypervolemia and TBI, in subarachnoid hemorrhage, we have also moved away from hypervolemia. This is a very oft-quoted study. It's relatively older now, in 2007. But we used to do this thing called triple H therapy, where you would administer hypertension, you would give volume, hypervolemic state was a goal, and then you would have hemodilution that happened, as the practice of care in the ICU. And it was thought that this 3-pronged approach was really neuroprotective in subarachnoid hemorrhage against ischemia or outcome. But it was very clearly shown this top row is measuring your regional cerebral blood flow, and on the bottom row is measuring your brain tissue oxygenation. And this was a stepwise approach where a protocol was administered to 5 healthy pigs and then 10 humans with subarachnoid hemorrhage afterwards. And what was shown was that the stepwise was first hypertension was given, and then these were examined in 1, 3, 5, and 7 days, I believe, or 1, 3, and 7 days after the bleed for humans. And then the second protocol, stepwise protocol, was to do hypervolemia and hemodilution without hypertension. And then finally was to administer all 3 together. And you see that what's the driver of improvement in regional cerebral blood flow and brain tissue oxygenation is really the hypertension. And either the hypervolemia and hemodilution, one of those things is probably contributing actually to the other direction, at least in brain tissue oxygenation. So hypertension is great. Hypervolemia may be harmful. Hypovolemia is actually quite harmful as well, we believe. So in this randomized study comparing the vasodilators versus the diuretics as a control for high blood pressure, when the lower blood pressure was a goal, the diuretic group was associated with more vasospasm, quite a significant amount, and more importantly, a greater amount of death. So from this kinds of study, it was thought that fluid restriction is also harmful. So what do you do? So these are more retrospective studies I'm going to show you now, where this is over 300 patients, and unfortunately, because it's retrospective, you do see something like as an imbalance after controls. You can see there's a lower GCS and a higher Huntus or clinical grade on presentation for the positive fluid balance group. However, the positive fluid balance group on the middle or the right column showed a higher degree of vasospasm as detected by TCDs and an increased length of stay, and that's with the positive fluid balance. And similarly, in this retrospective study, you see the third column shows the worse outcome patients were the ones with the higher net fluid balance, about 3.5 liters or so. Again, a retrospective study. So how does this all come together to define what we do? So we basically try to keep it even. We try to target euvolemia. You don't want to go too hypervolemic because that seems to be of poor benefit, and you want to avoid fluid restriction or hypovolemia. And when we talk about fluid balance, it's really simply measuring your ins and measuring your outs and trying to be equal. But we all know there are things like insensible losses. You cannot calculate and contribute to this number. We also know that 5,000 in and 5,000 out is a fluid balance, 2,000 in, 2,000 out. 1 out of 3 of our patients in the neuro ICU have a neurogenic fever, and so there are quite a bit of insensible losses, things that you can't even capture because there's body fluid loss in the patient bed. There also is no temporal information in any of the literature, so we know that these diseases are very time varying, and the influence of your fluid balance and what you're doing to your patients is actually impactful depending on what day and your prior probability and your posterior probability of events that are happening in real time. And we also know that just measuring what fluid goes in and what goes out is not a very good marker for what is actually intravascular, what's being seen by the brain. This, I think, is a very interesting approach where you're using a goal-directed hemodynamic management by measuring things about cardiac index, measuring your Getty, measuring also your fluid balance, and trying to really combine, as I showed you in that one slide of the, combining cardiac output, your cardiac function, your intravascular, your perfusion, and also your fluid balance, and looking at your outcome in terms of your cerebral edema and your cerebral blood flow. So in this study, they looked at when a patient with subarachnoid hemorrhage developed a delayed ischemic event or some kind of a neurological deterioration. They then went forth and they started to do hemodynamic measurements and tried to use a flow chart of what to treat first. And they would treat both. They treated both fluid balance using these the feedback of the monitors, as well as giving pressors. And they showed a reduction in vasospasm, in the neurological deterioration and infarction, but there was really no effect on the functional outcome. The same group went on and said, let's make this a little bit more complicated. It took me a while to even understand this flowchart, so I don't expect you to do that in this couple of seconds. I'm going to be able to show this to you. But what they did was they used a PICO, and that's also a flowchart, sort of an invasive and a more non-invasive and a little bit less not minimally invasive, intensive versus a minimally invasive, approach. And they showed that, again, you could reduce the amount of DCI in these patients, but they were reactive rather than proactive. And so it was until symptoms started to develop that they then went to start monitoring. So you see on the really low right hand, they don't even set up a system for measuring until you've developed DCI. This group went a little step more aggressively, where they started from the very beginning, and they had this very stepwise approach where they were trying to maintain, first of all, your MAP goal, and then they had prescribed use a balanced crystalloid in this setting, in this single center. They approached it looking at your cardiac monitors, looking at your fluid balance, not just your fluid balance, but how your fluid balance might be reflected in terms of your fluid responsiveness with your Getty, trying to target a number. And they had a flow sheet of how you would respond to this. You would do a certain amount of fluid. They actually used albumin. Then they would use balanced crystalloids, and then they would use dobutamine. And what's interesting, I think, most about this is on the lower left-hand corner, where you see that with the goal-directed hemodynamic therapy, this group had a significantly decreased amount of DCI. It was 32% in the control group versus 13%. This was a randomized control trial. And then in terms of the outcome as well, there was a significant impact on neurological outcome. But in the goal-directed hemodynamic therapy group, they used a significant less amount of fluid, interestingly. This is a relatively new study that came out, who we think is very compelling to want to use balanced crystalloids. We see hyperchloremia. We try to avoid that, thinking that in general in critical care that is a negative net benefit, so we try to do that. But this was actually definitively shown looking at the SMART trial. So SMART trial is a very large pragmatic trial looking at renal events, and the subset of these 15,000 patients had aneurysmal subarachnoid hemorrhage. And in that subset, there was like a nice balance between who received in a randomized way saline versus the balanced crystalloid. And while there was no significant difference in outcome or death, it was very interesting that death occurred quite a bit less frequently when saline was being given. The NCS and AHA guidance, I recognize I'm running out of time, so I'll quickly summarize here. The last few slides are really summary slides. The NCS and the AHA guidelines were updated this year in May and in June, and they approached the literature slightly differently. But in terms of fluid administration and hemodynamic monitoring, that Annexberger trial using the goal-directed hemodynamic therapy got a nod, and to suggest, yes, try to achieve normovolemia by fluid balance, and you could consider using a targeted approach using goal-directed hemodynamic therapy. And finally, this is your take-home slide. This is combining some of what I've shown you, as well as the ESICM consensus. But basically, target normovolemia, use crystalloids. In subarachnoid hemorrhage, you might prefer saline over the balanced crystalloids. When you're trying to figure out if you have an optimal fluid balance, try to go beyond just the ins and the outs. When you're starting osmotherapy, I didn't address this much, you want to have a trigger. You want to combine a clinical change. If you don't have a great exam, try to use neuromonitoring. You want to monitor the effects of your osmotherapy in terms of its effects as well as its safety, using a multimodal approach. You want to measure things like serum osmolarity, both to determine what kind of fluid approach you might give, as well as for if you have an intracranial hypertension event, when you should trigger using a hyperosmolar therapy. Avoid fluid restriction, avoid hypotonic, and generally albumin, given the mixed literature, we generally avoid it for both maintenance and resuscitation. And in TBI, avoid a higher fluid balance. That's it.
And we'll take questions. You start over here.
Soojin, thanks for an excellent overview. I just want to make one caveat with the advice to avoid fluid restriction. I'm not sure I totally agree, because fluid restriction suggests something that it may not be, in the sense that I think you should avoid clear hypovolemia in a patient with brain injury. I think we agree on that. But avoiding fluid restriction is often translated by clinicians that solving, for instance, low blood pressure can be done with fluids. But I think we should look at the cause of the hypotension. So that may be that you increase your sedation and then blood pressure goes down temporarily, which is often solved by fluids. But I think when you lose your sympathetic tone, you should solve it by catecholamines or norepinephrine, and not necessarily with fluids. So fluid restriction, I would say we should be restrictive, but we should avoid hypovolemia. So I think that's a nuance which is quite important, because we've seen in the TBI study that it's probably the case that we are quite unconscious how many fluids we give to the patients, because nurses at the bedside and also doctors tend to give the fluids, and then in the next shift they give more fluids, and in the next shift with different professionals they give even more fluids. So it goes unnoticed how many fluids we give. So I think restriction, we should be restrictive, but avoid hypovolemia.
I totally agree with you. I think you have to consider both a fluid when it's necessary to maintain a fluid balance, using not just your ins and outs, but maybe some adjunctive information, but definitely consider the hemodynamic things that you can do using vasopressors. And that's why I like the Annisberger trial so much, because they do monitor both, and they both take the action. And that group that had the hemodynamic monitoring was able to be given a restrictive fluid approach, but maintain euvolemia. So I couldn't agree more with that comment.
Thank you. We just have one last question here on the chat. What is your recommended strategy to maintain euvolemia in severe polyuric cerebral salt wasting syndrome?
Oh yeah, that's a good question. There's a lot of literature about this, and in different units go about it different ways. And basically, in subarachnoid hemorrhage, you have a high rate of natriuresis and cerebral salt wasting. And like we just discussed, what we do is we basically chase the amount of CC in, CC out. That's what we do. In one of our studies, what we were able to do is, when we're looking at perfusion, was probably a blood pressure issue. The patients who had a hypoperfusing state based on their optimal CPP, if you looked at their blood pressure, it was normal. If you looked at their fluid balance, it was normal, except that population had more infection. They had more pulmonary, urinary infections. They were having lots more insensible losses, and that contributed to a suboptimal cerebral perfusion. So CC and CCI is not adequate enough, but we try to do that to begin with. Other units might do a prophylactic approach and use things like salt tabs. They might use fludrocortisone. One Japanese study looked at a sort of a historical control where they followed urine sodiums And they saw that when your urine sodium started to escalate, then they started a more aggressive approach of using fluids or cortisone and fluids, and they were able to reduce the incidence of DCI in their single population in a historical control manner. But, we don't follow urine sodiums, but in general, if you start to see somebody picking up in their fluid output, you'll start to measure by, this patient got 10 liters of saline, in 24 hours, and we think, is this harmful? That TBI literature that showed hypervolemia is harmful, but the amount of fluid in, that was actually very encouraging for me because we are a little concerned about that when you have these subarachnoid hemorrhage patients, but we are quite aggressive, quite aggressive.
Thank you so much again, Soojin, for such a comprehensive review of another formidable topic, and I think we should go ahead and close the session. Have a good day, guys.